Hi everybody, I'm Niccolò Danesin from the University of Padova, Italy, and you today want to report some interesting works focused on WM that were presented during the two poster sessions at the recent EA Congress in Milan. The biological novelties and the new data around the role of BCL2 inhibitors and BTK degraders have been already presented by my colleagues in different videos. So we'll focus mainly on clinical data around disease prognostication and WM-related disorders. The Weill Cornell Medicine from New York City presented a validation analysis comparing the DFCI and Spanish model for predicting the risk of transformation from asymptomatic to symptomatic WM. The considered features were the percentage of bone marrow infiltration, the serum level of B2 mucoglobulin, albumin, and the serum level of IgM. The final findings support the superiority of the DFCI model in predicting this kind of transformation. A similar analysis was performed by the group of my center in Italy, where the cohort of asymptomatic WM patients were divided in high versus low bone marrow tumor burden, finding a shorter time to progression and a higher prevalence of karyotype aberration in the first case. A joint analysis from the University of Padova and Pavia in Italy highlights the independent role of abnormal free light chain ratio in predicting the transformation to active WM for patients with MGUS or IgM-related disorder and for patients with asymptomatic WM. These elements do not seem to impact overall survival. Another important abstract was shown by the English colleagues, and the topic here is the description of secondary immunodeficiency in patients with WM. The prevalence of hypogammaglobulinemia out of the entire cohort was 54%, with only 5% of patients receiving immunoglobulin replacement therapy. Of interest, those patients were not heavily pretreated with rituximab bendamustine as the most frequent regimen. No untreated patients with WM in this cohort received immunoglobulin replacement therapy. The American colleagues of the MD Anderson Cancer Center presented the poor cancer-specific survival outcome of their patients series with TP53 mutation. As expected, the ones who undertook chemoimmunotherapy with TP53 mutation displayed a worse cancer-specific survival outcome as compared to patients without TP53 mutation. And patients treated with BTKI display better outcomes. In addition, they shared also the long-term survival outcomes of WM patients followed in their center who discontinued BTK inhibitors due to progressive disease or the occurrence of adverse events and due to patient or physician choice. In the first case, better survival outcomes are achieved switching to another BTK inhibitors or to other single-agent therapies such as venetoclax. The reached median OS for those who discontinued BTK inhibitor was around 8 years. A small series of 22 WM patients with central nervous system complication, such as Bing-Neill syndrome, were treated with an oral covalent BTK inhibitor called tirabrutinib, and this work was presented by the colleagues of the University of Tokyo, Japan. Median time to best response was around 3 months, and EFS and OS at 30 months was around 90%. Safety profile of the drug was quite good without any discontinuation due to the occurrence of adverse events. It was great to see an increased number of WM works, also in the context of HIA meeting. And I'm pretty sure that in the next future, we will have great news for all of our patients.